Crucial nature of response-dependent management for septic patients in the ICU after prolonged bed rest. Case study. Sepsis is an unregulated immune response to a local infection such as pneumonia, and it causes global organ destruction. Septic shock is the worst form of sepsis, and it increases mortality risk by up to 40%. Its presenting symptom is severe hypotension, where mean arterial pressure falls below 65. And this is compounded on top of the already present pneumonia symptoms of fevers, chills, myalgias, tachycardia, etc. ICU-acquired weakness is resultant of sepsis and prolonged bed rest. It has a 100% prevalence in those who've been intubated for at least 7 days, and it presents as bilateral flaccid limb paresis and severe muscle atrophy. And this is commonly attributed to systemic inflammation, sedative medication use, and prolonged bed rest. So let's take a look at the literature here. On the medical side of things, vasopressor medications are typically used to increase blood pressure. Mechanical ventilation is used to treat respiratory impairments, and antibiotics are used to treat pneumonia. On the rehab aspect, early mobilization is commonly cited in the literature, and this is defined as any activity where the patient is actively participating, and that could be from the level of the edge of the bed onward. And this is ideally started within the first 2 to 4 days of ICU admission for the best results in psychological, physical, and cognitive domains to help stave off the development of post-intensive care syndrome, or PICS. Now, mobility itself has been shown to improve lower extremity strength, improve oxygen transports, and lung efficiency to help decrease ICU-acquired delirium by up to 20 days and help return a patient back to prior level of function. Response-dependent management is a strategy for safely administering intervention for high acuity patients. So with this, PTs can assess patients' physiological responses to increasing intensity or activity demands and use that to either increase or terminate activity altogether. Thus, mobility is titrated on a moment-to-moment basis, and activity can be prescribed to avoid overdosing or underdosing, and intervention is tailored to patient's exact specific intensity needs. This was the hallmark guiding factor for my interventions going forward. So with that, we need some objective safety cutoffs, and this comes in the form of vital signs. So I took the most common vital sign cutoffs from these two articles up here, and this was for termination of out-of-bed activity. So if a patient fell outside these ranges, we would terminate exercise, and that was if oxygen saturation was below 90, respiratory rate was above 30, if there was any angina, heart rate was above 150, mean arterial pressure less than 65, or systolic blood pressure less than 90 or above 200. My patient never fell outside these ranges, so activity was deemed to be safe. So let's take a look at this patient. He's a 63-year-old male with a past medical history of COPD, congestive heart failure, chronic bronchitis, and hypertension. He was emergently admitted to a different hospital where he was immediately intubated due to pneumonia, which progressed to sepsis. He was later transferred to this hospital for CRRT, and days later, on day 8 of admission, he was extubated in the ICU, and this is when we were ordered for PT for our initial evaluation there. Now, it is of note that this patient was not ordered for PT until this day, and that reason is still unknown as to why that occurred. On days 10 through 11, the patient saw 2 one-hour-long PT treatment sessions in the step-down units, and on day 12, the patient was discharged back to the SNF he came from. He was at a SNF previously for alcohol-related disorders and a fall history per his chart. This patient was bedridden for 7 straight days, so ICU-acquired weakness manifestations were definitely present. This patient was max assist for all these activities here. And of particular note, he was max assist times 2 people to help get him from a bed to the chair. 2 therapists had to help manually advance his lower extremities to get him to that point. The patient was unable to stand fully erect, and he had a hyperflex posture. He also complained of bilateral lower extremity pain and weakness. He also had lightheadedness, of which is probably attributed to a hypotensive response that was unable to be recorded because he only stood for less than 20 seconds. So looking at the broad ICF characteristics here, the main impairments are the leg pain, the weakness, and poor endurance, as we will see with RP outcomes. take a closer look at personal factors here. The patient was agreeable to my therapy as he wanted to get back to his previous lifestyle, being modified and independent with the use of a cane. He was also agreeable to my uh, discharge recommendations of going back to the SNF for continued rehab. And that becomes important because looking at environmental characteristics, this patient was homeless and lacked a family connection. Luckily, he was able to have good Medicaid insurance that was able to cover his stay there. So looking at the interventions themselves, they follow that response-dependent management approach. The functional mobility practice was my main intervention, and this included repeated transfers such as sit-to-stands, standing tolerance, and primarily the main intervention was a bed-to-chair transfer and working on trying to get that therapeutically. Active patient participation in mobility has been shown to improve quality of life and self-reported functional outcomes in those in the ICU. Evidence shows that functional mobility increases anti-inflammatory factors, improves alveolar ventilation, decreases delirium duration, and also improves lower extremity strength through enhanced muscle metabolism to stave off muscle atrophy. Of note, again, with our interventions here, a main priority was to target more functionally meaningful and higher level tasks, such as that bed-to-chair transfer, because the patient's going to need to be doing this task every day going forward. And then we save the lower, less meaningful tasks for later, such as supine therapeutic exercise or seated exercise. This is why I had the patient perform bed-to-chair transfers primarily with a front wheel walker, because it offered the patient stability, but to the point to where the patient can therapeutically try to initiate steps in a safe range with those two stability points. Outcomes were favorable across the board. Lower extremity strength improved, and I objectified that through the patient taking 4 active steps on the day before discharge. And endurance improved because the patient was able to stand for 3 minutes before requesting to sit down, as opposed to less than 20 seconds on that day 1. And all assist levels decreased, so that's huge for intensity purposes. The patient became minimal assist for all those functional tasks previously listed. Cognition drastically improved. Rating of perceived exertion showed some mild improvements, and this was for the toughest task, that bed-to-chair transfer. That's the reason why I have it listed here. The patients showed improvements with more challenging and more therapeutically independent tasks. And albeit, and we measured RPE as being meaningful because the patient was on a beta blocker, which is known as blunt heart rate response. And albeit still high, the pain rating was a 6 out of 10 at worst on the last day. And it was important to monitor this patient's pain status because we don't want him to be relying on opioids because this patient has a history of addiction. Looking at the AMPAC short form score, the patient improved from a 10 to a 16 out of 24, and this equates to a discharge recommendation of going back to a SNF or IPR for continued rehab. And that falls exactly in line with my recommendations anyways. So that range is typically 6 to 17. And so the patient stayed within that range throughout his whole visit, but saw substantial improvements. PERMI ICU mobility score is of note because unlike the AMPAC, it measures functional mobility based on observed tasks as opposed to relying on clinical judgment for tasks that are unable to be performed. So it's much more objective. There's also a cognition measurement component, so it's more encompassing. This patient improved from a 12 to a 21 out of 32, which is substantial improvement. However, still indicates there are major mobility deficits that need to be addressed in the IPR or SNF rehab. So overall, for managing septic patients with ICU-acquired weakness in the ICU, I found that response-dependent management was an effective guide for increasing intensity for this patient, and I felt safe and confident doing so, and the patient felt that way as well, so it helped build that patient-therapist alliance. I also found that targeting those higher intensity exercises, the more meaningful tasks like bed-to-chair transfer, was a lot more worthwhile for outcomes than supine or seated therapeutic exercises like marches or long arc quads. Because again, this is a task that the patient has to be performing every single day. Also, although this patient was outside the cited target window for early mobility of 2 to 4 days, we still saw substantial benefits and outcomes. So the the message there is that it's never too late to start mobility. And on the other side, however, we would have greatly loved to intervene for this patient in those initial 2 to 4 days of admission. We could have seen better outcomes that way. So that could have been something like mobilizing the patient to sit at the edge of the bed while he was intubated. Same thing goes for wanting increased therapy sessions. We wish we were ordered for PT much sooner so we can get that. And lastly, we desire to use more outcome measures like timed up and go or Berg balance to assess other areas of this patient's function like balance. However, this patient would score at the floor level.